is in my room, like
The dad?
the dad,
Okay.
on the phone with his son, whose son doesn't realize he's here yet, but he has Life 360'd his child, so he knows he's here. He's in my room. I get a call from radiology, and you're like, oh, hey, this is there. Not on the patient I'm anticipating this is happening, right? And he's like, hey, this is such and such and such and such, and your patient, you got this guy? And I'm like, yeah. And he's like, yeah, you have a thrombus. I'm like, yay! And then this is still happening, and I'm like, oh my goodness, now let me go. Now I'm trying to I'm
gonna shift gears.
Yeah, now I'm ordering heparins, and I gotta figure out who's on for vascular just to get them on board.
Life-saving measures.
And then off the phone, Dad, I'm like, okay, now we have to come up with a plan. And I understand, he wanted to be like, let's come up with a plan together. And I'm like, no, in this scenario,
not in an ER setting.
I have 90% of this planning process. You can either agree to the plan in this scenario, or I just do what's appropriate in this scenario and exclude you entirely.
ETFO.
Yeah. And so luckily it all worked out. But anyway, it was a mess. So after that, it was 2.5 hours of plus all the other patients that I had.
The sniffles and snots and sore throats and UTIs. And
I couldn't even look at their results because I couldn't get back to look at their results. So by the end of my shift, ask me how many charts I did.
0.
So that's a problem that I have to deal with today before work on a Monday. So, but I get home and then, I get to do an hour of algebra. I can't do math.
She hates math. She hates math.
I'm not.
I'll ask her, she's like, no.
Are you speaking to me in numbers?
Numbers? Never mind.
You need to say, Tara, we're about to speak in math. And I'm like, let me get my pen.
Hold, please.
I'm ready.
Google.
Numbers. Okay, now I have it written in front of me. Now I can input it into my mini handheld computer, and then I can understand what it's like. Translate. Google Translate for
math.
Non-math.
For Tara.
For non-math speakers. It was terrible. So that
Sorry.
all ended about 10 o'clock last night. Even Vance is like, can I go to bed? Yes. We can all go. Then you're like, blah, 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 blah.
Yeah, you vibrate.
You're like literally vibrate. Does that happen to you?
Yes.
Where you're laying there,
your body's
my whole body is just like, and you're like, I am never sleeping tonight. But eventually, you're like, does Jesus have knees? And you fall asleep. I wonder if.
Oh my God, I can't believe I survived 11th grade. You know that time? And I'm like, oh my God.
Okay. I wonder what happened to Joe Schmo in 5th grade. His mom was sick then. No, I'm not touching my phone.
I won't be able to wrestle until I look. Okay.
Yeah, I know. It's a whole thing.
Okay.
So, you're listening to Teens and Ash, the show where 2 real-life providers get real about health habits, wellness, and the broken healthcare system. We're here to educate, empower, and entertain you. One appointment-free episode at a time. This is healthcare without the bullshit. Today,
patient etiquette
and provider etiquette. We're going to throw
both.
Some.
Right.
So I was thinking about this last night. The interesting thing is we've been both. We're patient and provider.
Yeah.
Most patients are only 50%. Only patients.
Patient etiquette. We're going to talk about patient etiquette today.
And provider etiquette.
And provider etiquette, for sure.
Because we know both sides.
We do know both sides.
So let's just talk about what's your number one? If you had to pick.
Right now or in the ER?
Let's do both. Let's do outpatient and emergency.
Okay.
We've both done
my gosh,
both
there's
worlds.
so many. I need
you got to pick one.
Ooh.
Well, we'll talk about others, but you got to pick the biggest. Close your eyeballs, and in your mind, you're like, what is literally
if you're walking into an ER, oh my God, I can't pick one.
Yes, you can.
I need a pregnancy test. That's one of the biggest ones. We're like, no.
That's yours?
Dr. Google. Google says.
All right. So one of my biggest ones is 37 family members.
Oh, yeah, that's a good one.
I do not understand why we want to have our emergencies. And the things I potentially am going to say to you in front of your 30, I know you're like, well.
But they didn't know that.
But they didn't need to know. I mean, first of all, the rooms are like a closet.
Yeah.
And then there's me and you alone, a huge stretcher, a nurse minimally, a minimum of one nurse.
There's one chair.
A registration.
I cannot get you another chair for your 17 other family members to huddle up on.
Yesterday there was patient in bed, 2 patient family members sitting in roll later, kind of in the corner in the hall, registration clerk, 2 doctors, because doctor resident. So I literally just was like, hey, so this is what we're going to do today. If there's no room for me, so I'm just going to be like, everybody else got this? Perfect. Moving on. It was just like, I was like, why are there so many of peoples?
Yeah.
So that is actually my number one. And I will say that was my only thing that I actually enjoyed about COVID.
Really? It was great.
There was only patients, and I could speak to only patients first. Now, does that include your grandmother with severe Alzheimer's? No, I do not mean just grandma with severe Alzheimer's or your 5-year-old child alone. I understand those people need other people in the room with them, and I need those other people too, because I'm not really talking to grandma with Alzheimer's. I'm not really talking to a 5-year-old. I'm really talking to mom and caregivers. So get it. So those 2 are completely excluded, but I'm saying like under the age of, we'll say 70, with no significant like dementia onset or a quad. You're not a quad. I'll give you that. Or even a paraplegic.
If you require a caregiver of some sort.
A significant caregiver.
Yeah, a significant caregiver.
Yeah. I get it. But then we don't need your cousin who works on the 5th floor, and we don't need your brother who's coming by, and then
or your sister-in-law who's in nursing school.
Your sister-in-law who's a nurse or in nursing school. Like, can y'all just pass me a note? This is my input. And unless you have something significantly horrible to tell me.
Sure.
They're just not going to tell me. I get it. There are instances, but when I walk into a room and there's like,
just one person.
Hey, I'm Tarra. I'm the nurse practitioner. You're my patient. Mom, grandma, cousin, twice removed.
Pastor.
Oh, hey, you're the pastor. Nice to see you again. That's when I'm like, okay, everybody, it's a party.
We're here for the flu. Okay. Swabbing you.
So now all of you have the flu. FYI. So yeah, that's my biggie.
Yeah. Mine was, I guess working in triage a lot. Just, well, Google says I need this. I'm going to need you to order this. I'm like, no. Or I need a pregnancy test to prove that I'm pregnant. Well, did you have one at home? A positive pregnancy test? Yes. Congratulations. We're not doing one here.
Or a COVID test to prove you're
There's no reason for that. You don't have to have the documentation. They're not going to give you an appointment until you're 12 or 13 weeks anyway, past your first trimester, and you're pregnant. Yay.
Right. So patient etiquette. That's where we're getting at.
Yeah, patient etiquette.
And we start with patient etiquette because this is what I would hope from a podcast. We're educating the public.
The Gen Pop.
It's the Gen Pop. That is not on the provider patient side. So you're not a provider. And providers can be some of the worst patients ever to deal with.
The worst.
As like interactions.
They know too much.
Well, yeah, and that can be a whole bunch.
That's a whole thing.
But for the most part, none of us ever usually tell anyone.
We wait till we're dying.
Till we're way into it, or someone's like, hey, did you work at so? I'm like, yes. Yeah, that's me. And so that is, for the most part, how our provider as patients goes. Like, if you don't know us, then we're not telling you until you ask us specifically. Or unless I say something and you're like,
are you in the medical field?
So that's why we're starting on this side instead of
provider side.
Because the provider side, that needs to be addressed.
For sure.
Because patients don't always understand what's happening. So I made a list of etiquette tips. One of the first ones is your time etiquette. And this really would apply to pretty much anything, right? You be on time. If you're not going to be on time, call ahead. We mostly...
Not the ER. Don't call ahead in the ER. Just show up.
ER.
In the office setting.
Let's go to office setting.
Back to office setting. So the thing that annoys me the most in the office setting is when I give you stuff to fill out, like your history and things like that, I need to know that.
Right.
I need to know those things. Don't just go down and not click anything and say, I did it. And I'm like, okay. Because I use the information that you input on your history. I fling it over to my chart so that I can, get through your appointment faster. I can look at everything. It's all reconciled right there for me. And then we can move forward with your appointment. If you just decide to say NA on everything, And then, oh, wait, you listed your home medications, and you take a blood pressure pill and a cholesterol pill and a depression pill, and you take a BPH pill, and you take all these medicines, but you have no history. I'm like,
Okay. So now we got to stop and be like, hey, I see you're on 14 medications. So let's go through that. You don't have any medical problems? No, nothing, nothing. Okay, perfect. So why do you take lisinopril? Oh, for
yeah,
my blood pressure.
okay.
Oh, here we are.
Why do
Okay.
you take this blood thinner? Oh,
Yeah.
I had a stroke or a heart attack. Yeah.
Yeah. So big. Oh, yeah. Oh, okay. So that makes, so now we've just gotten deeper and deeper. And now we still can't address what you're here for because we got to now go through the stuff you didn't fill out on that paperwork that you find incredibly annoying. But I will say, let me flip the script here.
Flip it.
As a patient who is a provider, every single time I have an appointment, I get that same in other scenarios that I've been in, especially with my child. Every time I fill out the same exact form.
Not at this office.
Not at this office. But I get it that they have to update it, but I feel like sometimes, like, is any of this going to transfer over? But, well, whatever. But it does get on. But I do it because I don't want to be in that office talking about things that happened in, 2017.
Oh, that's another one. Sorry, that was the ER one. You just,
What?
so when did your legs start hurting? Well, back in Vietnam. And I'm like, oh my God, I can't. It started back in the Nixon administration. The first time I fell in a hole, and then I went to Nam, and I'm like, oh my God, okay, when did this episode start? Well, probably 5 months ago. No.
Mm-hmm. So
2 days ago.
What happened when you opened your eyeballs this morning? Let's see, happened that when your eyes opened, that's what I want to know. And you had this thought process. What happened? And you say, you know what? I need to go today. The ER.
I do. I need to go. You know why? I couldn't take it anymore.
A lot of times it is. I couldn't take it, which is fine. I like
absolutely. Just be honest.
Let's just get to that. So yeah, I know this has been going on a long time, but I did notice in the last 3 days, like, it's worse. And I did this. I did this. I did this. I can't take it. And perfect. I'm like, okay, excellent. 3 days. Will I note that you had a cry? Yes, yeah. But I don't need the backstory from the 80s. 90s,
I don't need
2000s.
Or you can gist it and say, I injured myself in 1984. Yeah. I had surgery in 1996. I've been in pain management in the early 2000s. And here I am. I get that. Yeah. Succinct.
Happens about 3 times a year. I get a flare, and this seems to be one of them. Huh, perfect. We have brought it all in. Yeah. There you are.
There we go. Okay, back to the office.
So that's a time, but back to the office. Yeah. So patients come in, and if we give you things to fill out, like, can you fill them out? Like,
yeah, we're not doing it just to.
What if we pull you back to the room before, like, we walk in? Fill it out anyway. Just keep filling out. We understand, like, sometimes we're moving fast, sometimes we're moving slow. So just, even if you're not done with your paperwork, bring it in there. Bring it all in there, and
we'll go over it.
We'll get it together. Together, we'll fill it out if we have to. So what about this? What about your appointments, let's say at 1 p.m. Or no, we'll not say 1 because we have a lunch. 2 p.m. Your appointment's at 2 p.m. You walk in, there's 3 people in the waiting room, 4 people in the waiting room. And your appointment's at 2, but it's like you got there a little early.
1:55 I got there.
You got there a little early. I'm super thankful for you. You are on it as a person.
You can use that time to fill out your paperwork.
You can. However, now it's like 2:10 and you're still not pulled back. My scenario, my concern at 2:10 is still zero concern as a patient. Once I get to like 2:15, I probably will stop and ask the front desk, like, hey, just wanted to clarify that my appointment's at 2. I was right, because I mean, it might be me. I might be wrong. So I always am like, it was at 2. Everything's fine. Did I need to do anything? Usually the front desk will take that as a yes. Hey, we're running behind. We just have a lot of things happening right now, and things just got backed up.
Sometimes it happens. We have no control over what walks through the door.
Right.
Same thing in an ER setting.
Same thing in the ER.
Where we sleep based on acuity. And we're going to do that here a little bit in the office too, absolutely. If we have people who are walking in the door who are primary care patients and they're having trouble breathing, or if they are in a ton of pain and they need intervention, we're going to address that. Even if they come in at 1:30 and we pull them back, your appointment's at 2, and they'll be back here, we're still doing things for them. Just be a little patient. You can ask the front desk. They'll be happy to help you. We can actually, pull you back pretty quick. That's what we do. We pull people back pretty quick. So
sometimes even if you get pulled back, you still wait because the other person in a room flanking you might be having a crisis.
Yeah, absolutely.
So this is what I want patients to think about themselves. It's a Tuesday morning. Yesterday, your mom died, but you are so you're like, I have this appointment, almost like robotic at this point, because you can't process grief. That is so insurmountable. You can't process it. You walk into your appointment, thinking I'm just here to get my blood pressure medicine refilled. And the provider walks in and like, hey, how's it going today? And you're like, so my mom died yesterday. And then I can't, as a provider, be like, wow, that sucks. So do you want 3 refills or 1? No, that's not what happens. I'm immediately also my gosh, let me stop what I'm doing. Let me not look at my computer. Let me sit down with you.
Let's create this space right quick.
Hand you some tissue, because obviously it hits you at that moment that this horrible event has occurred and you need a moment with me, and we talk about it.
Absolutely.
Now, if I were to say, hey, man, that really sucks. I'm sorry that happened to you. I'm going to refill your lisinopril. It's going to go to the Walgreens at the corner. 3 months? 3 months? 3 months good? All right. Thoughts and prayers. See you later. And then I walk out. I'm going to make the person's appointment at 2:00. That's right next door to you. I'm going to make that guy. But the person that I just left now is like,
what an asshole.
Yeah, you're right. That does suck. Thanks for my hypertension medicine. And then cries in their car. So that's the understanding, what is happening behind these doors is personal for each person. Same in the emergency room. When someone rolls in coding a drowned 3-year-old, a drowned 4-year-old, we're coding them for a long time. It takes a long time. I want you to think about that. So 1 minute I'm patient presents to the emergency room with right ear pain. And then I see horribleness fly by me. And I'm like, boy, let's go see what's happening in there. And if they need help, what's going on? Who's the doc going in? What can I do to help? When I was a trauma nurse, it was way different. I just was there. I was the team. But, you're just like, okay, we got this huge emergency. Most of the time we know they're coming. Most of the time. And so you're working.
Unless it happens in your parking lot.
Then you're working this big event, right? So we are coding another human who no longer has a pulse, who no longer is breathing on their own, who potentially is bleeding everywhere. We are the last thing between life and death that we're dealing with, right? Shockingly, that takes a lot of time.
What?
And so guess who now just got put on that back burner? Ear pain. I no longer can think about ear pain. So ear pain is gone from my existence.
You have to shift gears, change
now
modes.
I'm in ACLS, PALS, whatever's happening. And we are in this moment until it's done. Everything is shifted until something worse happens. So let's say we're coding pediatrics and a GSW comes in. Well, now we got to divide and conquer. So now we leave half of our team doing this and the other half of our team is doing this. Also takes a lot of time. So ear pain is still waiting. Ear pain, chest pain is still waiting. At that moment. That's how it works. I cannot leave and say, now hopefully there is another staff member or something that can be like, hey guys, when they call, you're like, hey, I've been sitting here for 45 minutes and haven't seen anyone. They said they were coming right back. When the staff member says, oh, well, there's been an emergency. We are dealing with that. They'll be back in. Hopefully they're saying something like that. So that's what's happening in the background. In an office setting, most of the time it's not emergent.
No.
But there are interventions that are needed.
Absolutely.
Breathing treatments, shoulders to cry on, things they want to talk about that they didn't want to talk about. They didn't want to tell the front desk people.
Right.
That's a big one.
Yeah, that's a huge one. Just tell us.
Just tell us. That's another one, yeah. But so if you're waiting for your appointment, I promise you, your provider is not watching YouTube and TikTok in the other room.
We're constantly moving.
Like,
we're constantly doing things for our patients.
There are
behind
other
the scenes
things happening.
Yeah, absolutely.
So that's that.
Okay.
What's next?
Respect your staff. Yeah, respect our staff.
Yes.
They talk to us. They tell us what you've said. They tell us how mean you are on the phone. They tell us that they're just,
And they are not clinical providers at all. So if they don't understand, usually they have to take a message and pass it on to us.
Because we're busy taking care of patients.
Because we're seeing other people.
Yeah.
So that means that it doesn't mean that they didn't do it.
No.
They did it. We just are seeing patients. And as soon as we get a second, we're going to be on it.
Absolutely. Be nice. They're just passing. They're the messenger.
They are.
Don't shoot the messenger.
So please don't harm them.
We need them.
And it's hurtful to them because they're not as, war wounded, battle savvy as some of us. So
yeah.
Turn your phone off.
Yeah. I turn my phone off.
Or even if you don't turn your phone off and it rings, like just beep. Silence. Please don't pick it. Hey, I'm in the doctor's office. I gotta go by. No, I'll pick him up at 4. I'll pick him up. I'll pick him up. Okay, bye. Just be like, click. We're going to get right back to that.
Yeah.
What else you got? What about if you have questions? I like patients to come with a plan or ideas and then we brainstorm.
Yeah, but a lot of patients don't even know.
I understand that. Yes.
Yeah.
But they know they're here for something, right? So in your phone, just jot down symptoms you've had. That's a good one. Especially headaches.
Oh, but don't Google.
Yeah, don't Google.
Oh my God, don't Google.
I mean, you can.
Everybody's going to die of cancer, apparently, with Google.
Yeah.
Or you have a tumor or a brain bleed.
If you're going to have cancer, use it objectively, right?
Yeah.
Did I say cancer?
You said
Google?
cancer.
I meant if you're going
to cancer, Google it.
If you're going to Google, it's going to be cancer. So,
yeah.
Be objective. Okay, I know you're going into it with, obviously I have cancer until proven otherwise by Google. Maybe skip down the line, scroll, further down, number 5. Say, migraine. Maybe it's that.
Maybe it is that. Sometimes it's the most simplest things. A lot of times, most of the time, it's not the worst.
It
just isn't.
What else do you think of? No food. Don't bring food.
Oh, God, don't bring food, especially if you've been nauseated. I'm just so hungry.
If you want to keep a pack of crackers in your purse, and then especially in the emergency room, we don't let you eat because our thoughts are, if we need to go, because we're in emergency room, remember,
we're ruling out the bad stuff
we
first.
Are literally thinking only the worst. So when you pop in and you're like, my ear hurts, I'm like, ear is going to surgery. That's what I'm thinking immediately. Until
and then we backtrack.
We figure it out that ear is not going to surgery. Belly pain, going to surgery until
always
proven otherwise. Doesn't matter.
Mm-hmm.
So do not eat, because if you do have to have an emergent,
appendectomy.
Yeah, exactly.
Guess who's going to yell at us?
Well,
the surgeon.
Guess who's going to put peanut butter crackers in their lungs if they don't tell us?
Delicious in the lungs.
It really is. It really works out though.
Yeah.
0 out of 10.
Anesthesia, catching attitude. Surgery, catching. Oh.
So then basically your emergency is now delayed, and we have to delay your emergency until, just to make sure your Big Mac doesn't end up in your.
I can remember working with a trauma surgeon. It never failed. Trauma would come in the door. We'd go to scanner and he'd be like, look, again, full belly. Everyone just eats before they get in a trauma. And I'm like, oh my God, nobody means to get in a trauma. But yes, their bellies are full. Sorry.
So you want to know something interesting? So my mom was a CRNA, and you know how from the ER perspective, if you are trauma related, we throw OGs and NGs almost in everybody.
Just about.
Right? Because in our minds, everybody has a full belly. And we're about to suck it out. And so I asked her one time, I was like, why don't y'all just put in NGs or OGs in the OR in these cases that are appendectomies from the ER or ectopics from the ER and what? And they're like, absolutely not. They're like, and I'm like, I never really thought about it, but they're willing to wait. I mean, it's controlled chaos at that point.
Right.
But yeah, we're just we're suctioning
We're tubing everything.
We're suctioning out, steaks, fillets, cheeseburgers, French fries. It's really delicious.
Yogurt's disgusting when you suck
little bit of alcohol.
Right.
So yeah, don't eat. I mean, unless you're trauma, you're not going to know. Everybody else, if you're making a conscious effort to go to a facility, don't eat. Don't drink anything. Maybe a little water is fine. Wet your whistle. Nobody's going to worry about that.
It's your whistle.
Wet your whistle. That's a big one for me.
Yeah.
What else you thinking?
I don't know. Just be kind.
Be kind.
Guess what? We go through stuff too.
Oh yeah, that was the other part of that working those codes.
Yeah.
When we come back to you, like you have no idea what we've seen.
You have no idea what we did in the room next door.
You have no idea.
My favorite really is the people that come to the door while you're coding and you're literally pounding on a chest and you've got chaos. I need a blanket. And I'm like, really?
I asked you for ice
20 minutes
ago. You're like sweating. Oh my God.
Y'all know how hard it is to do compressions? I can only do it for a couple of minutes.
2
to 3 minutes. I'm like, next.
Yeah, that's why we rotate out.
It's hard.
Well, you're not getting good circulation after 2 minutes.
It's tough.
You got to rotate it out. But the next day, you're like, wake up. You're like, oh,
I'm dying.
You're like, why am I in pain? You're like, oh.
That's why I like them young'uns to get on there and get on that chest.
Yeah, it's a wild ride.
I will say that if you haven't watched The Pit, watch The Pit, because that is truly, I feel like that's the closest thing.
I haven't watched.
Tarra, episode 8 did me in. Jesus Christ, because there's a kid code, and my last kid code was a little boy that was in my daughter's class. It was really, really, really difficult. I cried for 3 days. And I didn't cry. I didn't cry for years. We shut down.
Mentalize.
Ooh, totally compartmentalize. You shut down, you don't cry for 3, 4, 5, 10 years, and then all of a sudden one day that one patient comes in, you're like, 3 days in a row. Can't stop sobbing. Can't even eat. It's terrible.
So, and let's put that in layman's terms. So let's say your adult child seizes at your house. So we've all seen these big things. There's spit, there's vomit, there's urine potentially, there's injury, blood from biting their tongues. And let's say they have a seizure history but you're used to it, but this is a big one. Child has a seizure, grown child, he's 25, we'll say. But your job calls and is like, hey, did you get that report done? And you're literally on the phone like, I'm waiting for an ambulance. I'm like, yeah, no. I asked you 4 hours ago to get that report done. Mm. So it's the same concept. Mm-hmm. Like we are actively
we're moving through these emotions.
We are also, right. So that's the same concept. Most people, I guess, don't experience it enough.
No, we see the worst of the worst in a concentrated, focused, everyday basis in an ER setting.
Could you imagine if someone's job demanded hey, you need to get back. Like, your lunch is over. Mm-hmm. My husband's seizing.
Oh, sorry.
All right. 10 more minutes, and you need to get back in here.
Or we're going to write you up.
Yep. We're going to write you up. So
okay.
That would be an equivalent to a normal human's existence. Like, I'm assuming, right?
Yeah, this is a one-time thing.
Or if you got in a wreck on your way back from lunch and they're like, yeah, no one cares. You have people waiting on you. So
your job is here.
Yeah, yeah. Like, remember, we have a teleconference in like 15 minutes, dude. Okay, come on.
Yeah.
You can go to the hospital after.
When we're done.
You as a patient or as a worker would be like, absolutely not. Like, no.
Yeah,
but have a minute.
In an ER setting, it's
in an office setting. It's
move
with no regards to what is. And most of the time, it's not like us. Like, we've done this every day. Like, I'm not asking you to give me empathy
at all.
I'm asking you to give the people that I'm working on the empathy. Like, know that now we got to talk to family. There's going to be a lot of screaming. There's going to be a lot of crying. Maybe not in an office setting, but those people are the people that are here that need the breathing treatment or need an IV or need a medicine. Like, takes a few minutes to get that done and then make sure they're okay afterwards.
And there's a reason why we do certain things. Like, if you come into the ER and you have flown off of a motorcycle without a helmet at 20 miles an hour, I'm still going to put you in a collar. Don't get mad that I'm going to put you in a collar, because you could have a distracting injury, which is, I don't know, maybe a stick through your thigh. And that hurts so bad that you haven't paid attention to the neck injury that you could possibly have. So there's a method to our madness. We're going to cover you. We have this little thing called a differential. So it's a list of possible diagnoses that we're going to look at you and say, oh my God, it could be this, and this. So I need to do this, and this, because I need to make sure that you're safe and protected. We're just not willy-nilly doing anything just because, I don't know, it increases the bill. I don't know why people think that we just do stuff that's just unnecessary. We're doing it because at the time we think it's necessary and we're trying to keep you safe. So
what about this? What if in an office setting, you do have a lunch. Everybody knows that there's a lunch time. In almost every business, there's a lunch period, whether it's 30 minutes, whether it's an hour. But in those scenarios, it's posted. So when you call at lunch, no one's going to answer the phone.
Yeah. We have to take a mental break. Even in an office setting.
One, we need some food. We might need to, stretch our legs, might need to do some charts, might need to call, a pharmacy back that called us 3 hours ago. So from 12 to 1 in an office setting, most office settings, no one's going to answer your call. If you're cool with leaving a message, I'm sorry.
I was going to say, leave a message. We will call you back by the end of the day.
We'll call you back.
Yeah.
Okay.
Provider etiquette.
Okay.
Hit it. Go ahead. Provider etiquette.
Try to be on time, provider.
Absolutely.
Do your best. There's a whole thing about scripts out about like apologizing as a provider for the wait. Okay. And I have thoughts about that. In the office setting, I think it's appropriate because those people have scheduled times that you were supposed to be here. I'm supposed to meet you in your room, talk about your problems. I think it works in the outpatient setting.
Absolutely.
I do not think it works in the ER setting. I don't know why I'm apologizing for being pulled into someone else's emergency that I don't have any control of.
Right.
Like I didn't call anyone. No one made an appointment. I didn't know.
They don't make appointments in the ER, just FYI. So don't call and try to make one. Happens all the time. I would like an appointment for 2:00. I have an emergency. Well, if you have a true emergency, you just walk in the door.
Exactly.
Because if you're calling to make an appointment, guess what? It's not an emergency.
It's not emergent anymore. You've like negated the actual emergency.
Right.
I mean, really? Right? Like you're like,
you've outlived the emergency. And if you're waiting, that's the other thing. Oh man, I'm squirreling. Sorry. So if you're in the emergency room and you have a low acuity issue and you've been sitting in the
low acuity issue.
Oh God, earache, UTI,
foot pain,
cough, cold.
My eye itches.
Pregnancy test.
My child has lice.
Stuff I can discharge you from triage. That kind of low acuity stuff that you just need to come. Oh, I have a toothache. I need an antibiotic. I need to get out the door. That's low acuity stuff. And if you've been sitting in the emergency room for 12 plus hours with your low acuity issue, it is not an emergency. So don't get upset that we're pulling all these other people back. They're closer to death than you are.
And literally, that changes. Literally.
Absolutely.
While we're all sitting here, like if I have A, B, C, and D, currently, C is emergent, B is slightly emergent, 2 low acuities. Now, that would have been my initial impression. But once I get in there and figure out the foot pain is from
a blood clot,
an arterial clot, all of a sudden, my low acuity problem is now emergent. Now I got 2 emergents, 1 urgent, 1 low acuity. So that's how it's constantly changing just because they check in with tooth pain. And
if you get tooth pain, you're 86 years old, you're having a heart attack, hands down. That's just all there is to it.
Probably. There's not many lies there.
You don't have any nerves in the teeth anymore. So if you've got jaw pain, tooth pain at 86.
Claudication. Also, what if you're 23 and you woke up and your face is swollen? It's been hurting a couple of days, but you have a fever today, and all of a sudden your teeth you can only open it this far. That's an emergency.
I did that yesterday.
Even though you're going to...
What's that?
Even though you're going to check in and say, my tooth hurts. It's actually going to go like this. My tooth hurts. Like this. My tooth hurts. But there's no movement between the teeth. That's an emergency. I need to know about that a little quicker than I did then. Man, my tooth hurts so bad.
Yeah.
That's what I need to know.
Yeah. And we'll see that. And we'll get stuff started for you in the ER too.
In the waiting room,
in the waiting room. Stuff's happening. So we will also, in an office setting, so I feel like in an ER, we work, worst to best. In the office setting, we work best to worst. So we go down the low acuity scale first, just to make sure that, it's something really simple, because we're trying to save intervention, save money, make sure that we're not, drumming it up. It's not a unicorn.
Most of the time, it's not a unicorn.
Or a zebra.
Mm-hmm.
Yeah.
Right. Well, and, we don't have all of the things at our disposal. We don't have a lab and that right here that's going to give us a result. We don't have a
X-ray.
Scanner. We got to do things to get you there.
And we'll get you there. Absolutely.
But when you're in this setting, in an outpatient setting, like as a patient with a mindset of this is not going to be done immediately. We need to work to get to this.
Yeah, we're not going to
answer.
see one time and everything's going to be fixed, by the next visit a month later. That's just not how it's going to happen. Especially when it comes to weight loss, to hormones. Those take a little finesse. We're going to take a little bit of time with it. We're going to monitor your labs. We're going to see where we're going, where we're heading, how things are equilibrating out through the body. We're going to get you there. It's just going to take a little time. So don't think that you're going to come in and have a 15-minute, hormone replacement appointment in and out the door. No, we're going to spend about a good 30 to 45 minutes with you at minimum to talk about your hormones, all together. We're going to get your labs. We're going to review those labs. We're going to come up with a plan. We're going to discuss it. We're going to talk alternatives. We're going to talk risk and benefit. We're going to do all of those things. And then you can move on and start, weight loss hormones, things like that.
You're not going to feel better the next day.
No.
Not going to feel better the next week.
It may be a month or two.
It might be.
We got to figure out where you're going to go.
Forever. No, just kidding.
Hopefully not.
No, but literally forever, I guess, in like a colloquial way. But I always think 10 months to a year for hormones.
Mm-hmm. You're going to slowly feel better, but you got to find your sweet spot.
And then you as a person will change in that if there's a possibility you may go further into deficiency dominance that we have to then address again. So we're doing good, we're trucking along, but also we can't fix your life, man. If you're not sleeping, if you're not eating well.
That's the other thing too. I really need you guys to do your part. I had a physician friend tell me that you should never do more for a patient than they're willing to do for themselves. I can give you the tools. I can tell you how to do things, best practices, all that kind of good stuff. But if you're not willing to put in the work on your part, my part's not going to work for you alone.
No. And there's not we didn't do it intentionally.
Complete sentence is terrible.
We didn't do it intentionally.
No, absolutely not.
We weren't ooh, let's fail this one right here.
Let's do that.
No, that doesn't even make sense.
No, we want to help you. We want to make you healthier. We want to optimize your health altogether. We're not going to drag things out. What does that do? That just makes more work for us.
Well, we don't want you to be angry or unhappy.
That either.
So every time we talk to you, so we want to do things to make you feel better so that you can, do the best for yourself.
Absolutely. Another provider etiquette. I guess don't walk in with a chip on your shoulder. Try not to use the previous
interaction.
Don't let it bleed over into the next room. Because that person who came in with the ear pain, that is their whole world at that point. Ear pain's tough. It's like dental pain, ridiculously. It's hard. And so don't roll your eyes. Don't be don't be dismissive.
Why are you here?
This is not an emergency. They know that. If they had any other choice.
Well, and they may not actually understand emergency rooms,
urgent care,
let me say this.
Okay,
in a patient's defense, every emergency room has a low acuity area. So we're emergency. However, every one of them have a low acuity component or a rapid treatment area. You know what I mean? Where we are expecting to see things that are not dying. So when we say this isn't an emergency, well, right, everyone knows that, and we put them in this isn't an emergency area. So I think as providers we get, when we're jaded, I know, but for real. But I hate it when we do that and then literally amend this isn't an emergency area, and then are what are you doing here? And a lot of the patients don't know that, let's say these freestandings, they think are urgent.
They think they're urgent cares, and they're not.
They're not.
But they sure do bill you higher it's
not all of them. There's one that doesn't. But the others do. You're billed as an ER patient. So that's another interesting. But anyway, it's not the patient's fault. That's my point.
It goes back to that statistic again, where a bunch of ER providers were asked, how many of your patients are actual emergency patients? And they said anywhere from 15 to 25%. So that means 75 to 85% of people who come into the ER setting are not emergency patients.
But they still need care.
Absolutely.
Or they need education.
Yeah.
Now, let's flip the script on that.
Okay.
If this is your 13th visit this year, and you've had 13 doxycycline prescriptions and you want to be tested for STDs, again, we're going to have to sit down and have some
conversation about lifestyle
conversations
changes.
About that and about not coming to
An
the
emergency
ER
room.
or a low acuity setting for that problem. Like you obviously
Well, they come
don't
to the ER
understand.
because they don't ask for money up front. I mean,
True.
they do eventually, but you're racking up a huge ass bill.
3 times minimum
Yeah.
for even that, even more than that. It's even more.
It's crazy high.
But when people are, so emergencies or even urgent care things are things that are not repetitive,
Mhm.
right? So if you keep having intercourse with someone without protection, like it can no longer be emergent or urgent, period, continually, right?
One patient in my head who used to come in all the time, we had to use sugar on. You know what I'm talking about. Sugar 3 times a week.
3 times
Got on my
a week?
nerves. Yeah. So I thought, can you just go get a pound of sugar and take care of that yourself, please? Just look up sugar bridges. It's fine.
Chills down your spine.
I need some sugar. I'm like, I know. Damn it.
Right. Well, and also your inhaler getting filled. You know you're an asthmatic. You know your inhaler's ending. We've already refilled it 6 times. I've given you referrals 6 other times of other people to talk to about your asthma.
Again, it goes back to the provider who is running around trying to take care of the high acuity patients and a couple of low acuity patients. If you would just follow up where you're supposed to follow up with, it'll save you an ER visit, but it'll also not take that time away from higher acuity patients that need to be focused on.
Yeah. So think about it like that. So I walk into a room and it says, you know, cough congestion. So I have no idea what that means, really. That could be CHF and that could be I need my inhaler refilled. So I walk in thinking, I'm obviously, depending on the age, thinking, okay, we're looking at COVID, flu, congestive heart failure, COPD,
pneumonizing, necrotizing pneumonitis,
asthma exacerbation. And then I walk in and you're like, this is Bartis. You're like, I'm like, hey, what brings you there? You're like, oh, I need to get my albuterol refill. My albuterol refill, really?
Yeah.
So anyway.
That about wraps up patient and provider etiquette.
Yeah. Yeah. Both of us need to be empathetic to the patient and understanding of their time in an office setting, at least. But also, I need them to be empathetic towards their fellow patients and understand that obviously someone needed a hug or needed a breathing treatment or so that's what we're saying. Like, yeah. Now, if it's like 2 hours every time you're there,
that's a problem.
That's an issue. But 30 minutes, like
15 minutes and you have to wait.
Right. Oh, yeah.
I've waited hours before.
I have.
In an office.
As a provider.
I got forgotten about and left over their lunch break in the room. You're still here?
Even then, did you...
But I wasn't a bitch about it.
Did you...
No, I didn't berate the front desk either.
Did you threaten to fight them in the parking lot?
Absolutely not.
No, you didn't.
Yeah, that was a fun time too. That was in the ER though.
No, it's the ER, yeah. Anyway, so that's what we're saying. Have some empathy for your fellow patients and understand that you have no idea what they just told us and that they might need a hug, a big hug, and a breathing treatment.
I'm not a hugger.
That is funny. I'm not either. You're listening to Teens and Ash, the show where 2 real-life providers get real about health habits, wellness, and the broken healthcare system. We're here to educate, empower, and entertain you. One appointment-free episode at a time. This is healthcare without the bullshit.